Bismillah ar-Rahman ar-Rahim. This talk is sponsored by Pharmacon, this is a company which is responsible for the Alveofact. We start by a little bit of history. What's the history of lung surfactant? This starts in the 1805 when Young and Laplace, we are aware with Laplace, but it's actually Young and Laplace first formulated the formula for estimating the pressure needed to open a viscous organ, and it is a pressure equal to T, it's surface tension on the radius, and this will implicate the importance of the radius in determining what the pressure needed to open a viscous. Then in 1929, it was shown that the porcine lung demonstrate that the surface tension is low in the porcine lung which are born premature. And in 46, they first discovered the dipyromethyl phosphatidylcholine. In 47, the link between the surface active substance were shown to reduce the pressure required for lung aeration. In the 50s, they demonstrated that the pulmonary surfactant influenced the surface tension of the lung volume. All neonatologists are acquainted with Avery. This is the editor-in-chief of Avery et al., the textbook of neonatology, and he was the one who discovered the pathophysiological mechanism of RDS and stated that it is due to the lack of pulmonary surfactant. They found that the lung of a neonate who died of RDS had a higher surface tension than the neonate who died of non-RDS causes. And in the 60s, this was a turning point, the delivery of a son to Kennedy, and this son died from the hyaline membrane disease. And this incited the investigator all over the world to start working on a substance which can help in managing this. And in the year 65, this was the first clinical trial of a use of dipalmethyl phosphatidylcholine as a spray method for the first time. It was not effective. In 70s, Robertson and Adam reported the natural pulmonary surfactant formulation was effective in animal model, and Kings described the surfactant proteins which are important in the spread of the surfactant. Fujiwara was the first one to use pulmonary surfactant successfully in Japan. He was studying in America, and once back in Japan, he formulated a product called surfactant TA and reconstitute and use it in 10 neonate with RDS, mean gestation age of 30 weeks, and this was a great success. This was the first time of successful use. Then in Stockholm in Sweden, Robertson teamed up with Kurtstad to produce a porcine surfactant, and they name it according to their name. Kurtstad and Robertson, half of this and half of this, and they named it CuroSurf. CuroSurf from the name of the two authors. That's one of the most notorious surfactants you are using in Egypt, the CuroSurf, and this its history. What's the composition of surfactant system? 80% phospholipids, 10% neutral lipids, 8 to 10% protein. A small portion of the surfactant is protein, but essential for the function of this precious material, and 2% carbohydrate and iron. And this is the liquid fraction with the different constituents. The diphosphatidylpalmitylcholine is 40 to 45%. These are the different phospholipids incorporated, and these are the different proteins incorporated into surfactant-associated proteins. 4 types are up till now recognized: the surfactant protein A, B, C, and D. They're different than molecular weight. A and D are extremely hydrophilic. B and C are extremely hydrophobic. Up till now, the hydrophilic surfactant protein A and D are lost during the manufacturing process as a result of the organic solvent and chromatographic method. The hydrophobic surfactant protein B and C with the surface active lipids remain intact depending on the preparation. This is the structural picture of the surfactant protein. This is structural picture. This is the N-terminal and C-terminal, and this is a scanning electron microscopy showing in the lung, in the how surfactant is accumulated and packed. It is concentric, arranged layers and tightly packed. It is packed. It is not simply secreted. And this packing is done in a multi-layered surface film. As we see here in the multi-layered surface film, the packing of the surfactant. It is not merely the production, but the production and the packing. And we will see how important is the packing of the surfactant for the normal surfactant action. Surfactant, it is essentially an anti-atelectatic factor that's up till now the main role of its use. The application of surfactant lead to improvement of oxygenation, aeration, distribution, and the pulmonary respiratory mechanism is improving with increasing FRC, enlarge of tidal volume, and drop in the alveolar opening pressure. It acts as an anti-atelectatic factor, decreasing the risk of air leak syndrome, and hence in the long-term surfactant therapy leads to increased survival rate. The classic viewing of the constituent of the surfactant is a phospholipid, which act by reducing the surface tension, the surfactant protein B and C, which accelerates the film formation by stimulating absorption and spreading of the air-water interface of the surfactant. A and D are for local immunity. This was the old concept. We will see that this has been modified. The old concepts, the E and D, switch molecules between innate and acquired immune defense, and they are helping for virus neutralization, removal of bacteria, fungi, and regulation cytokine release, and down regulation inflammation. Actually, this is a new concept, a very new concept, which looks at the surfactant globally, and both the lipid and the proteins are sharing in the defense mechanism. Not only the surfactant protein A and D, but surfactant protein A, C, and D all are here, and they affect the growth and viability of the microorganism. And in addition, even the lipid together the protein, they inhibit the microbial infectivity. That's to say, one of the most important factors of surfactant not only is the surface tension lowering, but the defense mechanism to combat the infection. Both the lipid component and the protein component has got an important antibacterial effect and inflammatory modulating effect. The structure for the surfactant, the phospholipids themselves, although providing the molecule critical for the reduction of surface tension in the alveolus, they do not have the property inherent of surfactant. That's to say, it is the essential part, but it has got no functional characteristic of the surfactant unless there is. Why? Because it is a highly organized gel crystalline. The phospholipid molecule alone failed to rapidly spread and respread during compression and decompression. Where is the compression, decompression? The compression and decompression is present in each respiratory cycle. In each expiration, there is compression of this layer, and each inspiration, there is decompression. So if there is no proper packing system for this surfactant, it wouldn't function. And here lies the importance of the surfactant protein. Their adsorption rate to surface are slow, as they do not generate the stable surface tension lowering film necessary to maintain the surface forces during respiratory cycles. These surfactant protein B and C interact with the phospholipid to produce a unique physical characteristic during the respiratory cycle. And this, it is all about packing. How do you pack your active ingredient. If you do not pack it properly, you cannot use it properly. This packing, here is a cartoon which shows that during expiration, when the volume is declining, there is folding of this membrane, not a normal fold, but folding in this manner, so that this layer is transformed from a single layer to multiple layers, as you have seen in the initial scanning electron microscopy of the surfactant after production in the lung. It is arranged in layer. And then when there is expansion of the lung, there is spreading of this layer. This layer is a continuous one, multi-layered, so that you will ensure that during the subsequent respiratory cycle, the proper spreading of the surfactant will be effective, and the recruitment of the surfactant from the underlying layers will be effective due to the presence of these surfactant proteins. That's the method. While compressing, this will be invaginated and forming a second layer and third layer and more layers by this manner. And here comes the importance of this surfactant protein. Initially, it was thought that only surfactant protein B and C helps in this. And this is the surfactant protein C. It acts as a lever, يعني رافعة في الظروف العادية. الرافعة دي لما بتشتغل كأنها عارفين الشماسة اللي بتفرد مرة واحدة وبعد كده بتطبقها واحدة. الفردة مرة واحدة دي تعتمد على وجود السيرفاكتان بروتين سي اللي بيشتغل مع السيرفاكتان بروتين بي. هو رافعة بتؤدي إلى انخفاض اللير اللي جوه، ثم لما تيجي تحتاج ترجع تفردها بتعمل كده فترجع تتفرد as a single layer, and this is extremely important. Actually, newer investigation showed that the other surfactant protein A, which was thought to be as essentially only as a defense mechanism, is part of this folding system during the compression decompression cycle of the respiratory cycle. So the protein mixture, it is the lipid protein. Actually, surfactant should be considered as lipid protein mixture, not only lipid, because only lipid will not function. It should be considered as a lipid protein. In the airway, it should be there should be rapid adsorption to the air-liquid interface. Upon compression or exhalation, the lung surfactant must dramatically reduce the alveolar surface tension to near zero value, preventing the collapse of the alveoli, with rapid respreading during the work of breathing. So these are the surfactant proteins B and C and their importance in the normal function. When considering the surfactant present in the market, it started by the first surfactant to be available was called Exosurf, and I do remember when Professor Abdul Khaliq Khattab, Allah yarhamu, early in the 80s, in the 89, gave us a few samples of Exosurf to try to use it for the first time. Now it is no more available in the market. It was withdrawn, and these are synthetic surfactant, the colfoseril or Exosurf, polmactant, KL4, the venticute, and luminectant. Animal-derived surfactant are the beractant or bovactant extracted from cow lung lavage fluid, and Cervanta extracted from minced cow's lung. Here is lung lavage. Here is minced cow's lung. Berac surf, which is extracted from minced calf lung. There is the calfactant extracted from calf lung lavage fluid, and the poractant derived from the pig lung. This is the classification according to the methods of preparation. It is in animal origin manufactured by pulmonary lavage or by manufactured from pulmonary tissue or minced lung. Natural surfactant of animal origin manufactured from pulmonary tissue with additives. These additives are genetically produced proteins and added. These are not natural, but genetically produced and synthetic surfactant. And these are the names of the different preparations. It was shown those who studied the different composition of surfactant showed that when comparing two preparations, Surfactant and Curosurf, with others, they showed that they will contain less than 10% of surfactant protein B that is found in lung wash extract, present in Surf, Alveofact, and Bless. And here is the comparison between both the different types of surfactant with available amount of surfactant protein B and C compared in the three preparations. So do not restrict the use or the thinking of surfactant as to be used in hyaline membrane disease or RDS syndrome. In any condition where there is surfactant malfunction or surfactant absence, the use of surfactant is important, as in RDS, as in meconium aspiration syndrome and adult respiratory distress syndrome. Even in the COVID epidemic, it was used, the surfactant was used enormously in the management of severely respiratory, the pneumonia associated with the COVID, where the surfactant was deteriorated by the viral and subsequent bacterial infection. Here is the Alveofact. It should be used as a bolus within the first hour after birth. It is present in two forms, the 54 and the 108 milligram, easy to prepare with very easily to prepare. When comparing the doses, it was shown that using a high dose of surfactant, which is the 100 milligram per kilo, yield a better result. And this was shown previously in different preparation of surfactant. It is better to use the high dose, which is 100 milligram per kilo of the surfactant to improve the lung. So in the Alveofact, it is a 2.4 milliliter per kilo. Are we going to give a single dose or multiple doses? No, we think about multiple doses, and it was shown that using multiple doses result in the better improvement. Especially we should have a low threshold for repeat dose should be in consideration when there is history of perinatal depression or infection. Why? Because both of these are associated with a systemic inflammatory response and a local inflammatory response in the lung. And as we have shown, surfactant is a potent anti-inflammatory product, not only a surface tension load. Timing of surfactant, the best is to use it as early rescue, not the prophylactic and not the late. Early rescue, and or if the baby is in need for intubation in the delivery room, use it in the early period, is whenever the patient is intubated, is associated with a better response than rescue after deterioration of the patient. The Alveofact is a very peculiar preparation of surfactant. It doesn't need a cold chain. It doesn't need a cold chain. And this is extremely important in Egypt when the failures of the cold chain are extremely important, and it should be stored simply in the shelf in a room not more than 30 degrees centigrade, which is easily available. So what are the clinical studies? What do they show? They show that the Alveofact and the Surfactant group spent fewer days on the ventilator. There was no difference in the mortality or morbidity, but the need for ventilator was less. And the inhibition, it was shown that the presence of proteinaceous material or blood in the lung is associated with inactivation of the surfactant. But this was the least in the Alveofact, the least degree of inactivation and least reduction of the lowering of surface tension lowering effect was in the Alveofact compared with the other surfactants. So a great advantage, no cold chain, long-term stability without refrigeration, no warming necessary, remain stable after reconstitution. All of these are advantages of a natural product having the highest concentration of protein B and protein C, as we have shown, is essential for the normal function of surfactant. And thank you for your patience.
شكرا جزيلا أستاذ دكتور هشام.